So there are some challenging situations where it becomes a little bit difficult, and clinical experience kind of helps us guide through those. What's called subclinical hypothyroidism, which means that the lab testing isn't really, it's kind of borderline, as in was my situation. Type 2 hypothyroidism, where there is no activation. If the thyroid is absent from surgery or radiation because of Graves', that can be a difficult management patient as well. We talked about hormones and their impact. Obviously, pregnancy has a lot of hormone adjustments that happen. That autonomous or that mutiny scenario with the thyroid, that also can be a challenge to handle. So let's go through a few of these, okay? Not all patients do well on Synthroid or levothyroxine. In fact, over many, many years of practice, I've only had one patient whose numbers looked just fine on levothyroxine alone. Everybody else felt a ton better with combination dosing. Now, perhaps I'm biased because I only saw people that were struggling. The others didn't have a reason to come and see me. So, I don't know if you can relate to this diagram. I sure could. If you have a problem with conversion and you have that poor ratio between T3 and reverse T3, or you have an autonomous gland, there will be a problem. And studies have looked at how patients feel on T4 alone versus using either natural thyroid, which is a mixture of T4 and T3, or a combination of T4 and synthetic T3. And by far, patients report they feel better when they're on a combination. That has somehow not swayed mainstream medicine to adopt that strategy. So giving someone T4 who can't activate it is like giving a hungry child a can of soup but no can opener. So you're giving it to them, but they can't really make use of it. So in a normal, healthy condition situation, 80% of our daily T3 is made from T4, okay? Because mostly it is produced as T4 by the thyroid. When a person is hypothyroid and their thyroid isn't even making T4, and they're being treated with just levothyroxine or Synthroid, they must make 100% of their T3. So they're really critically in need of T3, and not everybody can efficiently convert it. There are some people who genetically have mutations that they cannot activate their T4 to T3. So they're not going to do well. They have no can opener. So stress is a very common thing in our society. And stress will tend to favor T4 deactivation into T3 so that you have increased reverse T3 levels and decreased T3 levels. And this will slow down metabolism. And emotional stress, physical stress, any kind of stress, the body handles the same way. So if you are lost in the woods and you're going to starve to death because of lack of food, you don't want a fast metabolism. You want a nice, slow metabolism with lots of reverse T3. But in our modern society, we don't really need that. And yet, we have a lot of stress, and so our body responds the same way. It makes a lot of reverse T3. And so it becomes maladaptive, although it obviously exists as a very appropriate adaptive response in the body. And again, at the bottom, I'm showing you there is a lot of medical literature to support what I am saying. So other causes where people will have difficulty activating their thyroid hormone axis, I guess you can say they have a broken can opener. Various medications, okay, beta blockers, very common heart medications that will really mess with thyroid hormone activation. Amiodarone, steroids, epinephrine, these are other drugs. Iron deficiency, inflammation markers in the blood, okay? Having metabolic syndrome, which is insulin resistance, that has an impact on thyroid hormone activation. Cancer obviously has an effect as well. So let's talk a little bit about this subclinical. This was my problems we talked about. TSH is a bit elevated or borderline, and the free T4 is normal. Okay, so there are studies that say that there is a benefit, and there are studies that say there's no benefit. So the doctors are like, well, geez, you know, okay, we'll just keep watching. And so the doctors are in a little bit of a conundrum as to what to do. There are definitely studies present that show that if you leave a person untreated with these little subclinical lab values, that they have worse rate of overall health problems, they have more, and they tend to die earlier. So there definitely are studies that support a benefit. But then again, there are studies present that do not support a benefit. Again, it depends on what are they measuring, who measured it, and so forth. The medical literature, you know, really can support two sides of the argument. You can find studies that support either side, and carefully weighing that evidence in each patient's situation is important. So let's talk about something called type 2 hypothyroidism, which most people and most doctors have not heard of. This concept basically really explains the so-called unexplained thyroid symptoms, where, geez, the labs are normal. So the patient's pulling out their hair and the doctor's suggesting antidepressants. So symptoms like chronic fatigue can be caused by this problem. And if you just empirically give these patients T4, you're not going to help them at all. It may make them worse. So the low T3 to reverse T3 ratio is the critical finding in these patients. And if that ratio is supported and reversed, it can make a dramatic difference in these people's lives. So in this type 2 hypothyroidism, the activation process is blocked. Okay, the T3 cannot be formed out of T4, and it's basically locked. So these patients, by blood testing, have normal thyroid function, what we call euthyroid. And yet they have symptoms of hypothyroidism. And so the TSH, free T4, free T3 are going to be normal. But if you look at the ratio will be low. And that gives you an idea that there is a problem. So the poor activation it basically goes undetected because, you know, T3 and reverse T3 are both ignored. And so if you have patients that have the subclinical or the type 2 hypothyroidism, they're not going to benefit if you just give them levothyroxine. And the question is, what if we give them the T3? What if we give them a combination T4 and T3? Can they be better? And in our clinical experience, the answer is absolutely. So these symptoms from poor activation are often present in early Hashimoto's disease. And so clearly I was struggling with this, and life was kind of a challenge as this poor woman is having. And if you use T3, it will bypass the poor activation. And T3 is available as a prescription medication. And that will restore the total T3 to the reverse T3 ratio.